Please give a huge round of applause. Welcome, sir. Welcome, sir. Welcome, ma'am. Let me brief you about the chair, Dr. Damodar Bachani, who is a visionary leader in having over 40 years of professional experience in health sector, in teaching and health program management at various national levels like National Program for Control of Blindness, Integrated Disease Surveillance Program, National AIDS Control Program, NCDs, etc. It's an honor to have such a highly learned and esteemed dignitary as the chair for this session. Thank you, sir. Among us is Dr. Devendra Khandait, who is the Country Lead and State Health Policy Director in India, Country Office of Bill and Melinda Gates Foundation. He has worked very closely with government, technical, administrative, and political leaders in the field of health system strengthening, human resource for health disease surveillance, maternal and child health and nutrition. Sir, we are highly ecstatic to receive you. We also have with us Professor Olga Plaza, who is currently working at RBCIS Bank, Luxembourg. She has 19 years of experience in different areas such as credit risk and AML KYC. She is also a CAMS certified anti-money laundering specialist. Thank you, ma'am, for joining us.
Ladies and gentlemen, good afternoon. My greetings to all the delegates and everyone present here. I would be briefing more about Mr. Rajesh Ranjan Singh, hello sir, CEO, Wish Foundation. As an international practitioner, he brings with him robust leadership experience as a social and community healthcare professional. Before Wish, he worked with several prestigious institutions which are as follows: Project Concern International, which is PCI, Concern Worldwide, Mamta, Health Institute for Mother and Child, amongst others. We welcome you all, sir. And now I would like to brief a little more about Ms. Richa Singh Deb Gupta. Hello, ma'am. And now, ladies and gentlemen, she is a Vice President for Fortis Healthcare with responsibility for PNL of hospitals in East Chennai, Chhattisgarh, and Mother and Child Vertical. She plays a prominent role of decision maker for consumption optimization, workforce productivity, conversion, centrally driven strategic initiatives around business turn and value proposition enhancement. We are delighted to have here with us, ma'am. And now I would request to start the session.
Good afternoon, colleagues, delegates, teachers, students, and all. Well, it's an honor for personally me to revisit IIHMR after full 12 months. It has not been a long time though. And thanks to Dr. Ruchi and other organizers for inviting us. And I also like to take this opportunity to welcome 4 dignitaries here who are specialists in their own fields. And it would be a good opportunity to discuss this topic of triple A's: accessibility, affordability, and acceptability, particularly around healthcare. Though it talks about well-being, but as the specialization particularly is around health. And we did discuss some of the other non-health sectors that affect health in the previous session. So unless some of you could go beyond, but we'll focus on healthcare. Well, India has not been doing very well so far as access is concerned. One of the SDG goals is to reach the unreached population, whether it is the urban poor or the rural remote or those who are living in tribal areas. There has been progress since 90s, and particularly since 2005, when National Rural Health Mission, which is now called National Health Mission, was initiated, but still we find a large gap both in service delivery as well as quality of care. If you look at the rural population, any indicator that you take, whether it is human resource availability, distance that they have to cover to reach even the basic health care, the differences are wide. And as a couple of speakers said in the last session, even the urban poor who are geographically well placed, but perhaps because of other reasons, their preoccupation with occupation, livelihood, and lack of awareness, they do not have access to health care also. And some of the indicators show they may be even worse off than the rural counterparts. How can we think about improving access to health care? Has the efforts that have been recently initiated through National Health Mission or Ayushman Bharat, which perhaps some speakers will discuss, are going to make an impact? Are there other sectors that need to be also rejuvenated so that health services are either the health related problems are either prevented through health promotional measures or the better service delivery system? In the absence of access to primary health care, fortunately, I had my first 5 years working in tribal area of Rajasthan. They had no choices but to go to the traditional systems, quacks, sometimes paramedicals. You know, the compounders became doctor in that particular area. And they used to call them doctors. They didn't know that they are not actually qualified practitioners. Or they just depend on home remedies, or maybe the second choice could be go to a pharmacist, because here without prescription you can get any drugs. मुझे कान में दर्द हो रहा है, मेरे बच्चे को डायरिया है, कुछ दवा दे दो. That is the sort of practice. Is it their faults, or is it the fault of availability of healthcare services through government or non-government means? The disparity is so wide. I was doing one analysis about ophthalmologists in this country when I was looking after eye care program. The availability of eye surgeon in urban areas is 1 in 10,000, and in rural areas sometimes 1 in 1 million. Was it not a big challenge? Whereas the problems related to preventable or curable eye-related services were required more for rural. But the disparity was there were more practitioners in the urban areas, whereas more patients were lying in the rural areas. So we came up with the innovations of vision centers in the rural areas, screening camps being organized by NGOs and things like that. I also recall when I was looking after HIV/AIDS program, when we visited one ART center. ART center stands for Antiretroviral Treatment Center. Those AIDS patients who require treatment in Ahmedabad, and it was overcrowded. When we asked them, from where have you come? Sometimes distance of 120, 130 kilometers. And they need to stay there for a couple of days because one day was not enough to conduct investigations. So being a student like you of health management, we researched and found a solution. Why not have what we called as link ART centers? Because we had large number of testing centers and we developed them, build capacities so that these centers can act as ART centers, and only once in 6 months to 12 months the patient was required to go for investigation, which were happening only in medical colleges. So that was the way of trying to identify problems and try to solve the problems. So we need to think about in what way we can improve access to healthcare. Can technology help? When I was one of the members of the Common Review Mission to various states, during my tenure in the Ministry of Health, we found some innovative ways. I recall one particular center in Vishakhapatnam. I think it was referred in the last presentation as EPHC, a primary health center which was totally electronic, no doctor. But there was, through telemedicine, a remote doctor who was able to guide the paramedics who were running this center. Is telemedicine the solution? Is home care based, particularly for those who are seriously injured or geriatric patients who cannot move? Home-based care is the solution to improve access? We need to think about it. So looking at the problems that happen in various parts of the country, we have to think beyond the box and think about what are the innovative ways to access healthcare. And unless it is done, the dream of reaching the SDG Goal 3 remains on paper. The second important aspect that we want to discuss today is the affordability. India, again, plays very poorly so far as the GDP for healthcare is concerned. The government spent just 1% of GDP on health out of around 4%. So roughly 3% is spent by people themselves out of pocket expenditure. And when I was looking after non-communicable disease, we recall the patients who are suffering from cancer or cardiovascular diseases having to spend money endlessly, and many of them had to sell their properties because they had to spend on such diseases. Is Ayushman Bharat going to help? Or Rashtriya Swasthya Bima Yojana going to help? Can we think of private sector and NGOs coming forward to give subsidized care? We need to think about it. Because I think last speaker did mention about that we cannot think about earnings, livelihood separately from health. If you look at the percentage of money spent on health in rural areas, sometimes it's 40 to 50% of their earnings because they have a chronic patient or some mental illness or some other disease in which they have to spend a lot. How can we reduce the out-of-pocket expenditure? Would remain a question to be answered. And the third aspect today is acceptability. I will add one more A to it, awareness also. Acceptability and awareness goes hand in hand. In spite of availability of primary health care, whatever form it is, people are not utilizing it because they are not aware of it. That's why they go to the quacks or pharmacies and other traditional systems. We have also a mixed healthcare system. I mean, India is a unique country with so much variation in linguistics, in culture and customs, but also, don't forget, we have a mixed healthcare system adopted by the government. So you will have an Ayush practitioner, you will have allopathic practitioner, and in some, even they are trying in Andhra Pradesh, they tried about what they call as a nurse practitioner. So we have mixed healthcare system and people have choices. In Calcutta, it may be homeopathy, which is more familiar among the Indian systems of medicine. In Tamil Nadu, it would be Siddha. Elsewhere in Gujarat, it could be Ayurvedic. So, I mean, government is still struggling to whether they should depend only on modern system of care or they should provide mixed healthcare system. And within that, awareness levels are very, very low. Whether you look at antenatal care, which has of course now improved, even institutional deliveries have improved, immunization coverage has improved, but still there are many gaps. Particularly for non-communicable diseases, in spite of free diagnostic care, in spite of free medicines, people just don't think it is disease. I mean, my last tenure was in the NCD portfolio, and when we used to ask the patient that you have a very high blood sugar, go to doctor, we'll give free medicine. He said, no, I don't have disease. Because their perception of disease was symptoms. And initially, unfortunately, I would say in NCDs, it could be totally free of symptoms, whether it's early cancer, pre-diabetes, pre-hypertension, pre-heart disease. You may have no symptoms at all. And their perception of disease is equivalent to symptoms. If they have toothache, they have headache, if they have fever, they will rush. But if they have silent diseases like hypertension, diabetes, cancer, they won't. So acceptability and awareness has to go hand in hand so that people realize the value of early diagnosis and treatment. So these are many challenges, and fortunately I have a very learned panel with me. We can begin with Dr. Devendra. He is from BMGF, had been dealing with health systems, a close friend. So we'd like to give him opportunity for next 10 to 15 minutes about your views on how to improve access, affordability, and acceptability. Thank you.
Good afternoon. What is the energy quotient of a room? Is it low, mid-low, very low, average, high, very high? What is it? Generally it has to be high, but post-lunch, it's a challenge for a speaker speaking in front of a bright audience post-lunch. Say it again. Yeah. So one of the thing which may I request is, I used to be a backbencher in most of my student life. But because I was a backbencher, I know what happens in the backbenches. So may I request at least those people who are occupying the prestigious backbenches, at least come forward. Okay, so can I before I start, I'm just curious. I want any two volunteers from the students. Any two volunteers. I'm not going to ask difficult questions. They can test me, and that's why it is easy. Any two volunteers, come this side. Great. There is a gender disparity, so I think only one. It has to be a balanced gender. One. Oh, no. I am not saying both. Yeah. Maybe two girls. No. One. Yeah. Both of you can come. Plus, it has to be a gender balancing. मैं आपको पूछ okay, it's very simple. Please. Okay, I do have a small question for all four of you. What is your expectation? What is your expectation from this lecture, so that I can accordingly modify my pep talk? Very frank, be blunt. This is your moment.
Okay, I would really like you to throw some light on the acceptability factor for all the national health schemes that are going on in India, as well as specifically on IIHMR Bharat, and the aspect that AI has been inculcated in health.
Thank you. Sir.
Sir, how it will be affordable for rural area and urban area regarding that?
Okay, thank you.
So, as Shruti said, more insights towards the Ayushman Bharat scheme. and yeah, more interventions, how something new which we can learn.
Okay, what's the name? Shruti.
Sapna.
सर आप
अंकित
आपका सवाल क्या है?
सर सेम इन रूरल एरिया
Okay. Thank you, Shruti, Sapna, Ankita, Neeraj. Please give them big round of applause for. Thank you so much. Okay. Speaking with the brightest mind is always a tough task, but I enjoy that. And thank you for inviting. It's such a privilege to be among the brightest people in public space that I see because I travel a lot. Are you coming, sitting there or standing there? So, एक बार. Oh, sorry. Am I audible now? Perfect. So, thank you so much for this opportunity. It's an honor, it's a privilege, it's an absolute pleasure to be here. Whenever I travel in the field, specifically nowadays in Uttar Pradesh and Bihar, I come across some of the students of IIHMR, and I'm really impressed with the sharpness of mind and the creative thoughts. And that's why I thought when there was an invitation, let me meet with the alumni network, or at least the students of that institution, where I may have the opportunity to learn from them. So, I don't know whether it is a good news or a bad news, but I am not going to use any PowerPoint presentation. I believe you had enough of PowerPoints in the last 2 days. No more, one more addition from my side. The way I have structured my thoughts is I'm going to talk about some of the opportunities and some of the challenges in these 3 A's, just with the caveat that these are my thoughts, these are my learnings based on my journey. You may find some resonance in it, some food for thought for all of you. I think people often ask me, are you optimistic in health in India? And my strong answer is, I am powerfully, superbly optimistic about India's health. People say, is it a politically correct statement, or are you genuinely feel that way? And I say genuinely feel that we have got all the reasons that we should have superb optimism in India's health. Because many of you may be born that time or not, and that's why comparison important. Say 1990 and compare 1990 and today, you talk about life expectancy, maternal mortality, child mortality, many other availability of the diagnostics, availability of the tertiary and secondary care, availability of the primary care. You talk about any indicator, and you will feel that, oh wow, India has come a long way in this journey. But in spite of this, in spite of coming all the way from 1990 to this, where I don't want to give you more numbers, there are enough numbers you have dealt with, so I just don't want to give additional number figures. But in spite of all this progress, accessibility, affordability, and acceptability, these are such a core quintessential elements of any healthcare system, and we are still discussing it, we are still grappling with it. I am not sure with how much time we will take to reach a reasonable level of these 3 issues, along with, of course, the quality issue. So the way we can discuss is, let's talk one by one. Let's talk about accessibility. Now, there are for a pretty long time. And there is a single reason, there is one of the dominant reason why accessibility is still a big issue in Indian setting or in our setting. We are all Indians and we are proud Indians, but in our setting, accessibility still haunts us. Any idea why there is a challenge in accessibility? I was a backbencher in the last time, so I know without a response, there is not going to be a monologue from my side. Whether it is 15 minutes, 5 minutes, 2 minutes, I need a response from the audience. What is the biggest roadblock in your opinion? Any volunteer will do. Hanji. Mike. You can speak from here, I can translate. Okay, great. He's saying the biggest roadblock in accessibility is awareness. Okay, let me use my thoughts. Let me share. Of course, that's an important parameter, but the point which I'm saying is the biggest roadblock in solving for accessibility issue for us is our own mind. We are so much constrained with our own thought process, in our own belief system, that this is the way we want to solve for accessibility. We are not ready to experiment beyond our traditional belief system. And whether it is a question of accessibility or whether it is a question of pursuing the public health career in your life, so long as you are completely marred by what is the traditional belief system, you will never be able to solve that problem. And that is our biggest challenge. We have traditionally defined accessibility as, geographical access. There should be time within this reasonable time. Initially it was a time, it was a distance. Then we matured into the time part. But the way we are saying is, okay, even if you provide the services in time, so what? We have not talked about accessibility from best-in-class diagnostic. We have not talked about accessibility best-in-class medicine. We did not talk about accessibility from the best-class service provider at the right place. Also, if some of you may have read a recent Lancet publication by Margaret Crook, the point she is continuously referring is, we are looking at accessibility from the same prism. We are using health as a monolith, and we think that this is the model which will serve for everything. Whether it is a family health, whether it is NCD, we will use the same kind of structure and the model. We will not differentiate for solving the accessibility issue. And this is not enough, because pragmatism, common sense is a rare sense, and so we don't accept the pragmatic solutions very fast. We take our own sweet time to accept the pragmatic solutions. Our mental framework doesn't commensurate with the change in the ecosystem, because there are IT changes which are happening, there are infrastructure changes which are happening, and we are still while there is a lot of change in the ecosystem, we are still thinking from our traditional way of solving the accessibility issue. We cannot serve all at the same time with the same intensity. We will have to differentiate our approaches. And for that, what is needed is a clean data set, clean data system, and many times unavailability of the clean data is also one of the important challenge that comes in the accessibility. So you may ask, oh, you just said you are very optimistic and you have mentioned all the possible minus points, so what? But I think there are many promising things which are happening in the ecosystem. If you look at Government of India's recent focus on aspiration district, or Government of India's recent focus on Mission Indradhanush, which is essentially for the marginalized, most disadvantaged. If you look at Government of India's focus on IIHMR Bharat, that means we are now unapologetic about secondary and tertiary care. For a pretty long time, we in the health system were a little bit apologetic about secondary and tertiary care because we only believe that only the primary health care is the only way to go. We had started private sector as one of the important stakeholder. For a pretty long time, in addition to the trust issue, we were thinking, oh, by the way, that's the partner, not a necessary close partner and important partner. We thought it's one of the partner. Let's talk about the recent TB strategic plan, which talks about private sector and the public sector in an equal way, or the whole case of IIHMR Bharat. This gives hope that we are looking at the health services of all and not to the ones which are only coming to the government facilities. We are faster in accepting the diagnostic. For example, if you are talking about CB-NET for TB or ivermectin for lymphatic filariasis, these are the newer drugs which has got the huge promise or quickly turning on the situation. We are fast enough in accepting that. We are pragmatic now. We are more pragmatic. The recent GOI decision about increasing the medical seat without actually increasing the infrastructure, utilizing the existing institution, that's the case in point. Or acceptability of DNB district model or the College of Physician and Surgeon model for specialist creation, that's the additional point. The models like Bijapur model of Chhattisgarh, which looked in a comprehensive way for attracting the medical care providers in a most remote area, is a classical point to tell how the accessibility issue can be addressed in a composite way. And nowadays, more and more, I was teaching in Labasna, which is IS Academy in Mussoorie, and again, the same model was discussed at length. So I see a lot of appetite there. I think one of the core reasons why this happens is there is an inherent disrespect or a no respect for implementation science. One of the inherent reasons we are still discussing this issue is we are still driven by upstream research, we are still driven by academics who are telling the how part of it. We are still not differentiating what is how and what is how, what is what and what is how. I think the time has come to give more and more focus on implementation research, operational part of it, implementation science, and I'm sure IIHMR is doing service in that. Before I talked about affordability, because I see the two panelists who can speak on that subject more than me, let me talk about acceptability issue, because that was the one which was raised by my 4 friends which have volunteered. You might have the best intentions in the world. That doesn't mean that you can design the services for the poor or for the people. For a significant part of my career, I spent in polio eradication, and polio eradication gave me enough reasons to believe you may have all the reasons in the world, but people may still not accept it. You have to create a pathway where your well intentions are well accepted by the service provider and the community. And I was trying to understand the reason why this is the case. Because acceptability is nuance, it is contextual. For example, I will give you one small example. You know the ASHA network in India. It is a frontline worker at the village level. Now, same ASHA is effective. I was working, so we had a grant with Sargo Foundation and we had a grant to University of Manitoba. So both worked together. It was University of Manitoba supported by Sargo Foundation and Gates Foundation. They came up with the findings that the same ASHA is effective in institutional delivery, in immunization, in some of the changes in the neonatal health, but same ASHA is not effective when she is delivering the message on the family planning. So same service provider, same community, but still there is a difference. Another dimension of acceptability is, if I am the corporate CEO and if I want to improve the customer satisfaction, the important tool I will use is, how do I manage the HR of my service providers? Because it is my service provider who will be in touch with the last person. Once they are happy, they will provide the happy services. In health, either we are working at this level or we are asking whether the patient is happy. But I don't think we have given enough attention to the human resource aspect of the service providers, whether it is security of the doctors and the paramedics, whether it is HR best practices in that setup, whether the incentives to the ASHA, whether the timely payment. Recently, I was very positively impressed there was a National Innovation Workshop in Ahmedabad, and UP got the first prize. UP got one of the best practice of UP got appreciated was, they could timely make the payment to the ASHA. Now this is such a basic. Now you have to have the timely payment to the ASHA is making to the National Innovation Summit itself talks about how much we care about our service providers. One of the additional hindrance is we states don't have the capacity in the BCC space. If you talk about the service delivery, they are great. If you are talking about supply chain management, do it. But if you are talking about behavior change communication, states have limited capacity. We don't have the right expertise on there to manage the SBC and BCC campaigns and all that stuff. Fortunately, newer and newer players are coming and they are trying to improve the capacity. Some of the recent MOUs are in that space, and that makes me super optimistic about acceptability part. Chair, if you are to have 1 minute, I can talk about affordability, or otherwise I can leave. Okay. On the affordability, I think you must have heard the IIHMR Bharat. It's a great start. It's one of the best start in the affordability space. I think because this is a gathering of IIHMR and I cannot stop myself from sharing this principle. Basically, finally, at the end of the day, there are three principles. There are three global types for successful health coverage models. One is the typical national health service model, which is funded through the general taxes, but what is requirement is you need a strong health system. Second is the social health insurance model, but what the essential requirement is you need a strong regularized informal sector. Third is the managed competition. It's a nuanced one. And fourth is the mix of all that. What can I essentially talked about is, and some of the closest countries from where I get impressed is Thailand. Now, we do have the composite models in place, and the closest link we can draw is from Indonesia, where something like a composite model. For the poor, it will be through the taxed, and for the formal sector, it will be through the social net. I think it has to be some mix of that. Ayushman Bharat gives me a lot of hope that we have started thinking about it, and I hope many students of IIHMR will play an important role in taking these three issues in the long time to come. Thank you so much. Thanks for the patient.
Thank you, Dr. Devendra. Now, request Dr. Olga Plaza for her views. 10 minutes. Thanks.
Yeah, it's okay. Thank you. Good afternoon, everybody. The first thing I would like to do is to congratulate the university for the big effort in organizing all these points of view that we have shared already and create a network, improve the health system. I came here to give the students a vision of Europe, to explain a little bit the healthcare system in Europe and how can we work together to improve our health system, because we have problems and challenges in both sides. My opinion now is that even if we can collaborate in projects like to improve the environment or to study how to develop new medicines, cheap medicines for everyone, the root of the problem, I believe, and we can discuss that, is education. If we provide people with good education, they will be able to create a system where could be acceptance for everyone. So, and that create that the people have good jobs, that they can afford a healthcare, and the other thing, acceptability come together, everything. So what I will invite you is to take advantage of all the knowledge the university is providing you, so you can go out when you finish and to work in your work health system, so you will have a big impact in the improvement. Because you already have already identified the problems, you know how to solve these problems, and now what you need is to have a government that creates the right policies that allows you to work together with the private institutions or private partners in order to have the healthcare system you deserve for everyone in India. So the government has to work very closely with the private partners, and they have to give incentives so they can work better, or can provide the service better. They can, I don't know, I think about low taxes or low interest loans or freelance to create hospital. But I think it's the government who has really to give the first step and quickly provide you these rules and regulation so you can have a structure that you can safely and solid implement your health system in India. What do you believe? I don't know. I think that a country cannot progress if they don't have an educated people, and the educated people can do all this and more. And the India country is amazing. I was impressed. I came here and said, okay, Europeans can help the poor Indians, and now I'm gonna go back in a few days, and I said, I think India can do more for us, that we can do more for them. We only can, no. The only thing we can do is just collaborate in little projects. I don't know if we can do more than that, because you already have the knowledge, you know your problems, you know how to solve it. You just need the government and an active private partners who build all the things you have spoken these days. And this is all I have to say. I don't know. If someone has a question or someone has anything, we can discuss after. And thank you for everybody for all the support you have provided me during these days, for your hospitality, and believe me, you are a great country, so you have to create the health system you deserve.
So both the first two speakers were very optimistic. That's good for all of them. May I now invite Dr. Rajesh Ranjan Singh. When were you a doctor?
You met me.
Okay. Mr. Rajesh Ranjan Singh, more than a doctor, CEO of the Wish Foundation, for his views. And I would particularly, and the audience would be interested on your involvement in Mohalla clinics of Delhi as one model for improving access.
So I remember Shruti and team asked a question to Devendra. Let me take an attempt and quickly respond it. So Shruti, wherever you are, Ayushman Bharat has made a dent, and has been in the form that, I think if I remember right, in until end of October, almost 50 lakh beneficiaries have been benefited by that. Almost, if I remember correct, 13,000 crore by August, I remember those numbers there. So huge number has been really reached out, and obviously, even if you take knowing the India in mind, I think even 70% of those are actual investment and beneficiary, still a huge. So if you really come out with 70% of 50 lakh, you will really calculate how that. Having said that, has it really created accessibility? Well, the question is that yes and no. Yes, I already answered no. I'm going to really just say that the irony is that the Ayushman Bharat has two verticals. One is Health and Wellness Center, and the second is the insurance part. So what I talked about, the number is the insurance part. Does it really synchronize and talk to each other? Not yet. And that's something which happened when Ayushman Bharat celebrated its 1 year. There was a deliberation, and one of the, they call it Manthan, and one of the 5 outcome of recommendation of the Manthan is to really marry these, the Ayushman Bharat, which is insurance, and the Health and Wellness Center. So that's the background. I think partly I responded, partly Devendra you can really respond to. So I represent Wish Foundation, and the foundation, well, it's an irony that whenever and wherever I go, because I worked in health, and I work with either the PhD or the MBBS, that I get also called by doctor names. I feel proud, but I'm not really doctor. Hopefully I can really get time to come to institutions like IIHMR to get my PhD done. Thank you very much, Dr. Thank you, Dr. Pankaj Gupta. Thanks, Ruchi, for inviting me. So let me just tell you the story of 3As from the primary health lens. Our personal belief and philosophy is that, nothing works in isolation. So if I really work in primary health and I don't really complement and create a critical patient or client pathway to the secondary and tertiary, it's not going to really help, right? It's going to really block somewhere and the connection won't happen at all. That's how people like Dr. Richa is here, that she really is going to complement where I really leave, she will pick the thread from there. So the whole primary health, the theory of change is that my foundation works is that if you really strengthen the primary health, what is going to happen is that primary health from the last mile health perspective, you're going to address the issue of accessibility. Now, I'm going to really give a twist to this, merely saying that accessibility is not going to work. So there are thousands and thousands of health centers, primary health centers and sub-centers, where it's accessible, but it's not available. Services are not available. So when I talked about accessibility, I'll really Yep, thank you. I'm on it. So I'll also include the availability in mind. This is about the institution that I really work with. Probably we manage roughly around 300 facilities. We are roughly around 500 of the staff. And the reach currently is around 16 million. And the beauty is that all these data are on the tablets. So people who really manage these programs, over the last 3 years, we have really evolved, and almost all the data are being captured through the online system there, and these are real-time data there. I'm proud that out of the 400, at least 5 or 4 of them are IIHMR graduates there. So congratulations to IIHMR again for giving us the right talent. I'm going to really, again, as Dr. Saab said, that probably I'll highlight some of the models. So our work is primarily in developing the models which really addresses the issue of the 3As there. We have models like Mohalla Clinic, and the beauty is that the Mohalla Clinic currently is being replicated in 9 states. Some of the states which itself is supporting the state, but in some states, the state itself, like Telangana, they really learned and they piloted, and now they're in a scale-up mode there. And each of the state has really improved upon and brought their own perspective into the framework that they picked from Mohalla Clinic. So the preamble is same, but whether it's Telangana, so they call it Basti Dawakana. Maharashtra, they call Apla Dawakana. Jharkhand, they call it Atal Clinic there. In MP, we are supporting in Sanjeevani Clinic. So you name it, they have evolved from the basic framework that Mohalla Clinic developed it. This is a peculiar, really very, game changer kind of urban primary health aspect, which has really addressed the issue of accessibility. It has also addressed the issue of affordability, and because of this, there is a higher level of client satisfaction. There are external and internal data and evaluations being done by various schools and students, including the IIT Delhi one, that really clearly shows that how by developing the Mohalla Clinic model initially in 1 lakh population and now gradually around 40 to 50,000 population, the aim is that every 10,000 population there will be a Mohalla Clinic. And please understand that each Mohalla Clinic caters to the need of roughly around, on the average, around 150. So 150 minimum. It has also evolved, and this year we started the evening Mohalla Clinic also. So meeting the unmet need and especially keeping the accessibility part for the working class. So the casual workers, those who are really working during the day. It was accessible because the clinic was close by, but the services were not available. So those around 38 of the Mohalla clinic which are functioning in extremely the slum-dominated population is where it's twice a day there. So 5 hours in the morning and around 5 hours in the evening there. There are models of primary health in tea garden. So traditionally, as per the Tea Plantation Act in Assam and other parts of the country, especially Assam, we work and our foundation work with a Tata Tea amalgamation entity called APPL. And what we developed is that we really help them in transforming the whole primary health system there by bringing the new innovations. So innovations of how to do the business, which is providing services, the doctor's skill set, the frontline functionaries, a soft skill set, not only the hard skill set, also the attitude of the service provider within those primary health care. So a lot of effort has been really given, and that attitude part comes from most of the time from the acceptability perspective there. In fact, the state that I'm here and we all are here, I'm proud that the first model of rural primary health center that WISH really piloted was in actually. And our genesis, WISH existing, happened because we piloted around 31 rural primary health centers, and these are all far-flung areas there, which were almost, the services were negligible or minimal there. And we found by really improving A, the timing, B, the availability of the doctor, C, the attitude of the service provider, the D, the capacity building, whether it's a soft skill or hard skill, D or E, bringing the new innovations into, so point of care devices in the hands of the frontline health functionary, and the most critical part, which is the last one, is the data analytics part. So if you really record the data online, you can really see online and you can really triage it. You can really create algorithm based on this for better decision making at the senior level, at the implementer level, and also at the frontline health functionary level there. A lot has been talked about health and wellness center, and just to really let you know, as the health and wellness center concept, so the health wellness center concept of the government of India is that you transform the originally it was sub-center. However, over a period, most of the state, they realized that even their primary health system doesn't really work. So then they said, okay, rather than sub-center, let's focus on the primary health center. So then it was agreed between the center, which is central government, and the state, that have a hybrid where some will be sub-center and some will be primary health center. What we did over a period of time, that since we had certain innovations in mind, we already were piloting various point of care devices, and the data was uploaded through the Bluetooth and the server. We really brought this tech-enabled health and wellness center, and these are centers in the far-flung where when you enter, the client enters, to exit, everything is automated. And that's something which we piloted in around 4 or 5 states, and it got a lot of traction. So states like MP is now scaling, and they have put on the RFP, and hopefully we have agreed to support them in scaling those models there. As we really gain these experiences, some of the states approached us, and they said that, hey, can you really help us in ideating, conceiving, conceptualizing, and implementing it? So we said, why not? Though we don't have a deep pocket, but our foundation gladfully agreed to support us, and in 3 states, Assam, MP, and even in Rajasthan, we are the technical support or knowledge management partner to the state government and health and wellness center, and various other areas of primary health, especially the comprehensive primary health aspect there. I think, where does the well-being come into picture? Dr. Bachani talked about that most of the speakers will talk about health. But I'm also going to really touch the aspect of well-being. If you really have seen the Health and Wellness Center concept, you will see the mental health is a key component to that. From the well-being, the yoga has been brought as one of the 12 services there. The states are not fully prepared, and they're looking for support from agencies like IIHMR, like WISH, like Bill Gates, the foundation's partners, and other agencies to come and support them there. Some of the digital health that, since the world is moving, we have also evolved over a period of time. So no more manual data collection. Everything is digitized. And the idea is that we have actually even moved from digital health, using digital health lens to really get into the artificial intelligence and machine learning. Thankfully, we have a sister organization called Vadwani Initiative for Artificial Intelligence, and we have had an advantage to work with them in using our data for artificial intelligence purposes. These are the examples which I have really already spoken about. So in terms of accessibility, timeliness, in terms of and availability of care, these are very, very critical components to this. Affordability is from the out-of-pocket expenses. So whenever you really, if a patient comes and a female comes to the center, and if the doctor is not available, and if the doctor is available, if mobile pathology is not available, this person will again lose her wage and has to go to the CHC or the district hospital. Can we really provide those laboratory assistants, which are within the Government of India mandate, within the primary health or sub-center level? There are clear guidelines to this. And mind you that the government is also very, very open for new learnings. We started in sub-center only 38, and as per the mandate, only 38. In fact, 32 plus 8, or 31 plus 8, something like 39. In Rajasthan itself, in sub-center, we have around 88 medicines there. And this is the Rajasthan government which gave us the blanket permission to really bring those medicine and provide those medicine through the government system in the sub-centers level. This is a classic case of Mohalla clinic where the doctor is using the tablet every 1.5 minutes he was seeing, but now we came with because the client satisfaction was low, and we said that now every 3 minutes you can only do a consult. So technology can be a facilitator for enhancing your performance, and it can also be blockade if you really try to be extra efficient because doctor every 30 seconds was a patient was being really recorded there. So now we have really come out and we said every 3 minutes you have to spend, and the second client can only be observed or treated after 3 minutes there. Acceptability, even a mere aesthetics of a primary health center, for that matter, any. Why Richard's Fortis Hospital is really swanky? Because the moment you enter, you get good feeling there. So if you really see the same center in 2016 and end of 2016 and early 2016, see the difference there. It really boosts up. It really gives you a different kind of feeling there. Basically, if I really try to give you a few pointers, so we also need to think about the equity in this, and especially from last mile health, if we don't really consider equity aspect from the accessibility, acceptability, and affordability, we'll be actually defeating the purposes there. So how come our services are more friendly and open to the women there, especially in rural? The urban situation is not that good. In fact, Dr. Bachani in his address, he really talked about how we can really make these services available to the home. So a simple point of care device, if a ANM can really take it for the screening purpose, that woman doesn't have to really go to the district hospital, doesn't have to really lose the wages there, doesn't have to spend time and money on the transportation there. I remember when I started working in terms of acceptability, my boss, who is the managing director of Rockefeller, she told me way back in '87, she said that, so how many invites you get it? I was working for Plan International. How many invites for marriages you get it? She kept as that as a thermometer for my acceptability as a program officer within the larger community development program that I was managing in a big slum in Delhi there. My point to you is that, ladies and gentlemen, that if you really stick to those parameters where the community accepts not only your services, but you as a human being, I think that's a big parameter and achievement for us. Our goal is that when India will be 80, we'll be 75 in 2022, but which has kept a target of 2027. We would like to really reach out to around 100 million in India and global. So thank you very much.
Thank you, Rajesh. May I now invite Dr. Richa Devgupta, Vice President, Fortis Healthcare, for her views.
Ladies and gentlemen, and dear students, as an alumni of IIHMR, it's actually a homecoming for me, and thank you very much for having me here. Being the last speaker, it's always an advantage and disadvantage, and I think I'm going to use it as an advantage. I've got quite a few slides, but I would like to run through those which have been already spoken about. Subject is such that probably I studied it at IIHMR in 1998, and it still continues. That says the state of affair that we are in. But having said that, I think I'm also a hardcore optimist, and I'm optimistic that India is making progress as far as healthcare is concerned, and will continue to do that. Only thing that worries me is the speed. That's something which we need to expedite, so that health for all is something which I can see as long as I'm alive. So with that, I would start. So while we say there are 3 A's which are important, which is accessibility, affordability, and acceptability, there are a couple of more which I would add is, one is availability and one comes as accountability. Now, let's look at it. Now, healthcare, sorry, I think one slide has been missed, yeah. So, Supreme Court says that healthcare is a fundamental right for everyone. But having said that, spending 1% of the GDP at national level is something, I don't think that makes the scenario better, because affordability remains a challenge, accessibility remains a challenge. Now, look at this. At one point, we are saying accessibility is a problem. There are less number of beds, less number of hospitals, less number of doctors. But at large, if you look at it, private healthcare provider who provide actually almost 65 to 70% of healthcare, secondary and tertiary healthcare to people, the occupancy level is only 60%. And if I go by the government data, the utilization of government hospital at IP level, it remains at 45%. So that goes on to say that there is a huge gap in terms of how we use this facility, whether it is worth taking or not. At the same time, if you just look at the picture below, it also talks about that some of the hospitals, probably we have 3 patients lying on the same bed. So that's the disparity, and that's what I say, that while it is a fundamental right, but fundamentally, somewhere we are not moving in the right direction. Okay, now WHO, basis one of their studies, said that around 57.3% doctors who practice allopathy are actually not trained allopathy doctors. Well, but still, if you look at these pictures, these people are crowded, whether it is in the rural area and even some of the urban area. A person who's not even an orthopedic doctor is trying to fix the bone. And I don't think any of us would not have had seen this sight in your respective areas wherever you live. And then I'm sure you're aware that some of the trained doctors are getting beaten up in private health care sector as well as even in the government sectors. So that's the disparity that we have. There's quickly a timeline on the healthcare in India, and I'm talking about largely the hospital sector because that's where I belong. If you look at it in 1664 to 2018, more than 300 years have passed, and that's the journey that we have covered. And there comes Ayushman Bharat. I'm not going to talk much about it because that has been spoken about and there's much available. So we would move on from there. Just to mention, Fortis Healthcare actually started in 2001 as one of the private healthcare players. Now, availability, affordability, accessibility, and acceptability, these are the pillar of healthcare, and especially universal healthcare, where we are talking about healthcare for all. Affordability. Now, let me tell you, and I'm sure all of you are aware, that when we talk about healthcare cost per se, we are 1/15th time of US like to like in terms of our paying capacity. And when we compare another Asian country, which is Malaysia, the prices are actually half of Malaysia, what we offer in India. In spite of them, it's not only private healthcare, but at large we have this feeling that healthcare in India is very, very expensive. So one reason what you can denote to is that there are like 3 countries within single India. One is those who can afford it. Second is those who comes in the middle income. And the third, which is the largest segment, those who can't even afford what the healthcare should cost. And when we come on accessibility part of it, the challenges that we face is distribution and reach. We're well aware when we talk about distribution, it is also about distribution of doctors, that how many of them actually wants to work in urban sector and how many wants to go into rural sector. That's something which we need not debate here. Now, availability point of view, if you see, I would just read the last picture that I have put in. If you look at it, that worldwide average is that you have 30 hospital beds, whereas in comparison, if you compare in India, it is only 12 hospital beds which is available. Rest of the things are statistics. I leave it up to you to just quickly go through it. These presentations are available with all of you. Awareness and acceptability. Now, role of private healthcare provider, what I have quickly tried to do is that while we have spoken about that these 3 A's are problem, what is that a private healthcare provider tries to do to minimize these gaps? So focus on making healthcare affordable. Now, what we are trying to do is that, see, when you talk about pricing, as it is, India has this tag within the country that we are very expensive and more so in private healthcare players. Right? So what we are trying to do is that while your inflation rate is around 4 to 6%, but prices are not going up in the same proportion. At the max, the prices goes up by 1%, which is just not sufficient for a private healthcare player to survive. So best option is to introspect, and the 2 options that you can do, your profitability can increase. One is that you recover it from the patient in terms of pricing. Second is you introspect and improve on your own system to reduce the cost. So that is second methodology, is something which private healthcare has adopted. And the areas that we look at it is the 2 stage of it. One is when you're planning the hospital. Second is when you operationalize the hospital. So planning, there are quite a few things that you can do to make your hospital more optimal in terms starting from what positioning you want to have for the hospital, what area you're located in, what are the services that you put into that hospital, and so on and so forth. And when we talk about operationalizing the hospital, few of the fundamental things that you need to look at it is, one is your consumption or the consumable that you use in the hospital is a large chunk of your profitability and profit and loss. So what you need to do is selection of consumable that you use without compromising on the quality of consumption. Second thing is monitoring the consumption. I'm not getting into the details. Third is about the manpower. Manpower constitutes anywhere between 25 to 27% of your P&L. So that becomes a very, very crucial thing for you to look at it. And then comes the area of quality. Now quality, I have always heard that there's a debate that when you get into improving the quality, there is a cost also involved. But having said that, let me take you a quick example. That if you have a patient in the hospital, and if he acquires infection, hospital-acquired infection, the patient is going to stay for much longer and the cost is going to go up. So better work on quality and ensure the patient is turned out from the hospital as soon as possible. Reducing variability, process effectiveness, and asset sweating are some of the things that we're working on it. Implement change to support cost efficiency. So anything which you devise, I mean, once you make the plan, obviously you have to implement it, you have to sustain it, and you have to then monitor it to make sure that it continues to run. That's the way you make your journey cost effective and hence pass on the benefit to the patient. Improving accessibility. Some of my co-panelists spoke about technology, public-private partnership, and better insurance penetration. So these are the terms when you're, and technology, I think in last 5 years have changed significantly. We are talking about patient app, we are talking about doctor's app, we are talking about disease management apps, which are very, very effective, and some of them we are already using it. In telemedicine, you can have teleradiology, teleophthalmology, telecardiology, EICU, which we are also using as a tool to reach out to the people. Public-private partnership, advantages we are all aware of, and some of the hospitals where we have public-private partnership with the government and some of the other partners from the industry. Insurance penetration, it's abysmal, it's quite low, but at the same time, the graph gives you an indication the growth that it is getting into it. So these are our efforts in terms of reaching out to the public, having health talks, educating the doctors, having continuous training program for that. Now, let me emphasize for a minute about the accountability. See, quality is one of the aspects wherein accountability comes in. Whatever you're delivering, is it up to the acceptable mark? Do you have consistency in your services or something? So I actually take pleasure to announce that, Fortis Healthcare is first organization which actually publishes, it goes on to publish in its website the clinical outcome for top 15 to 17 procedures. And that's where we talk about transparency also. And this also helps you improve the acceptability of the services. Because today, everything is available from a small nursing home to a larger hospital. People really do not understand where the cost difference is coming from. These are the reasons, and this is where you can justify that it can also improve your acceptability. Strengthening focus on the quality and service standard. On the first two columns that you see are the sum of the clinical parameters that we monitor, and it gets monitored across the group and then compared, and we ensure that any deviation, any change or low marking gets worked upon and is improved upon. Training, I would say, is the backbone of the healthcare organization, and with that, I would stop here. And I think having so many students, it will be good to have a larger question and answer session rather than we talking. Thank you very much.
Thank you, Dr. Richa. Well, thanks to all the speakers for being in time, and so that we have at least 8 to 9 minutes of question answers. Kindly raise your hands, introduce yourself, and to whom that question is directed. Can you please manage the mics? We lose a lot of time in just sharing the mics. Couple of mics may be floated around. But yeah, they take time to reach,
Hi, I'll just start as the students are getting prepared. My name is Anuradha, and I work as faculty and Dean of School of Development Studies. When Prime Minister Modi launched IIHMR Bharat from Ranchi last September, I think it was clearly said Tier 2, Tier 3 and rural is going to be a challenge. My very specific question is, as we see 1 year later, two very important things is lack of number of beds, and financing is an option for every private sector hospital in terms of returns in financial returns towards the services provided. Because we have an esteemed expert also representing a private sector, and we have an NGO also in the part of this. I would like to do this. How do you see it as a challenge?
We'll take questions first and then answer. And I would like to promote this question answer mainly from students.
Good.
So, but yeah, faculty are invited, but mainly from students. Yes.
I am Dr. Disha Jain from the second year HM batch student of IIHMR University. Today we have talked a lot about optimism. So what I would like to say here before asking my question is that I think healthcare providers of current generation has to be realistic, because the famous quote which comes into mind when we say optimism is about the glass is half full. But if you're realistic, you will also say that the glass is half filled with air also. With that question, with that background, my question is, we have talked a lot about the accessibility part towards the care seekers. But what about the accessibility of proper technology and resources towards the care provider part?
Yes, good afternoon. Sir, I think so. Three of the pillars go hand in hand. If we see the acceptability, accessibility, and affordability, I think so. The consultation in tier 2 cities are accessible because they are private hospitals everywhere, but they are not affordable for the middle class people. Like if we see the dermatologist or the ophthalmologist costs too much, like 2.5K for a dermat, or like one minimum 1,000 rupees for a opthal, and it is not affordable. But if we go for a PHC or PHC, so the quality of the treatment which is given is not acceptable, not up to that level compared to the tertiary. So how can we fill this gap?
Disparity.
Which is disparity. Okay.
Last question.
So,
Okay, so my question would be,
Who is there?
sir, I have this question.
my question would be that considering the public good character of the healthcare, that it is non-excludable and non-rival, so how can we, also considering that India is one of the most privatized healthcare in the world, where 3/4 of the outpatient and 2/3 of the inpatient is dealt with the private sector, how can the private sector hospital play a role in being co-opted with the government agencies in improving the accessibility, affordability, and also acceptability? Because there's a virtual breakdown of trust. There's denial of treatment, there is over-diagnosis, and there is also over-treatment at times, which is breaking the trust of the general public as such. So my question would be, how will the private sector leverage to that?
Last.
Thank you, sir. My question to you is, with relation to yesterday's session, which said about e-pharmacy, how rural people could be able to access these services where they don't know how to open their bank accounts properly.
Why did you not ask yesterday?
Sir, it is about accessibility, right? That's why I use this.
Okay, because I was not there. So I don't know. All right. The rest of you can ask questions during the tea break. So there are questions around
Sir?
Ayushman Bharat. Would you like to answer?
Excuse me, sir. It's a
Excuse.
great call. The last one here. I was standing here for 5 minutes now. Can my question be the last one?
It is already over.
I was.
Be short.
Okay, so the question is, my name is Bharti Verma. I am the first year student of HM batch. And I would like to ask that you were talking about affordability to the people, as India is segregated into 3 countries, as by ma'am, but we are in a position where decent living standards are still yet to be achieved. So how to achieve that first so that we can focus on affordability of health?
Okay. So there's question around Ayushman Bharat, disparity, access to technology and resources, role of private sector. And the last one, again, about the 3 countries within 1 country. So would you like to answer a couple of these?
Okay. Yeah, technology, yeah. Okay, I guess. I think these are great questions. I cannot speak without standing, so excuse me for that. I will go from back to first. Bharti Verma's question about how to achieve access to all when there is a disparity in wealth quintiles, and what should be targeted first. I wish the life would have been so bipolar or siloed ki, okay, one at a time. Let's raise the income first, and then let's raise the accessibility issue, and then let's raise the quality. Life is complex, life has to come together, so all this together. It is not, today's generation is an aspirational generation. Can you afford, okay, I will take care of only wealth quintile part today, quality, let's talk 20 years from now. Nobody is going to accept that. We have to find the right middle ground into synergistic efforts in all three. Disha's question about glass is half empty, so much optimism. I think it is good to understand. So sometimes we go into the two different direction. Either we say we are there is a complete helplessness situation, or we are too good in everything. I think it is important that we realize the beautiful innovations which are happening in different parts of India, some of the good progress happening in some of the important areas, and how can we learn from that. I don't think I can give more specific than this, because I think we are aware of the time. I think I will at least two questions, I think, from my side.
There was a gentleman who asked a question about the private healthcare. Can you repeat your question, please?
So my question was, ma'am, my name is Rishabh. My question was that healthcare is primarily a public good, which is non-excludable and non-rival. So my question was that how can, and because India is a highly privatized healthcare we have seen in the country, where most of the outpatient and inpatient care is given by the private sector as such. So my question was that how can the private sector be an agent and an engine of change in this respect, helping the government sector to improve the accessibility, affordability and acceptability of the health services in India? Because there is denial of treatment in most of the private sectors, hospitals. There's also overdiagnosis seen in the media reports, and there is also over-treatment which is done. So the majority of the people who are primarily unaware are the victims of such things. Thank you.
So the question of yours sounded more like coming it from a generalist rather than a student who himself is studying healthcare. But having said that, let me answer this. See, I think healthcare, how it gets delivered is grossly misunderstood by the media. Okay? And as I said, that while Supreme Court, Honorable Supreme Court has said that it's a fundamental right, we also have to work collectively more so as a public responsibility that healthcare should be affordable. However, currently where we are, it's a midway, right? That when you talk about private healthcare, please know that healthcare is subsidized for the poor patient, is charged to the middle income group, and probably slightly higher for the people who can afford royal suites and private rooms. This is how we are trying to bring in that balance, because end of the day, please do understand that these private healthcare people are business entity with a heart. Why I say with the heart is that yes, healthcare is a subject matter wherein if a patient comes to you, you have to deliver services to them, more so in a life-death situation. Because I would be candid in saying that some of the patients, when they turn up to us, and if we think that they can sustain the treatment for few days, we do refer back to them to the government hospital, right? But however, wherever there is a threat to the life, we immediately take the patient. And as I said, the cross subsidy is something which we adapt to treat these patients. And in terms of diagnosis, in terms of whatever that you keep hearing, it is like, taking the same paintbrush to paint the whole thing in one color. I think that's not the right approach. I would not say that no, that the malpractices does not exist in the system. It does, but generalizing it would not be fair.
Thank you.
I think it was a question by the young lady there, Disha. So you asked the question, and you live in the world which really uses technology for everything. 10 years past and today, where are we in vis-a-vis technology? So why not in the health? And if you really go back and see that there is a really very vibrating ecosystem at this point of time. So I'm not promoting any party or any person, but I think the current India, the way startups have been initiated, the ecosystem, both at the private and at the public side, if you really, Ayushman Bharat, if you see this Startup India, Make in India, they have this, you heard Bayrak talking, you have DBT talking there. Everywhere, if you see this, right from medtech to the technology backbone of this. If we don't use it, and you start from the clinical side. So initially, the clinicians were using their wisdom to really see the patient. Today, they have CDSS. Earlier, they used to have ICD-10 software to really help them. Today, they have SNOMED City. You click it, and it will give you the option. You further drill down, it gives you further specific. So the actual treatment has become really a precision public health phrase has been used there. For data analytics, you heard me talking there. If you have a right data sets, you can check. Ayushman Bharat uses AI for fraud detection and management there. The frontline health functionaries, if they have AI tools and algorithm in hand, they can really identify the high-risk pregnancy right in the community there. So if you really give these tools and provide the right training and backup and support to these health care providers, which is primary healthcare providers and frontline healthcare, it's going to really be a game changer in transforming the whole healthcare in India.
Thank you. मेरे को मालूम था तुम आओगी. Well, just to summarize few take-home points, I think the panel did suggest that we are optimistic. India, particularly in the healthcare scenario, is going to improve. And it's not just only in healthcare sector. We are progressing very well in various sectors which are directly or indirectly affecting health of the people. So we need to be optimistic. There was a few issues that were discussed which are perhaps important for IIHMR also to look when you get your dissertations. Some more research, particularly implementation and operational research. That's an area. I think what Government of India does are making policies and technical guidelines. How it actually needs to be implemented on the ground varies. So the schemes need to be flexible, and it will depend on the geography, the culture, the context of the local situation that need to be taken into account, and therefore we have to have flexibility for which we do require implementation research. So why don't IIHMR give at least few topics, important topics during your dissertation, particularly those who are dealing with health systems on this particular aspect. Well, behavior change communication is a very complex and difficult thing. There are traditional values, cultural values, which need to be changed over a period of time if they are not accelerating or promoting health. That's a big challenge. And I don't think we require counselors or educators. Every healthcare provider has to be counselor. Doctors, nurses, pharmacists, everybody, ANMs, ASHAs, Anganwadi workers. We need to, continuously hammer population about the correct aspects about health and health promoting issues so that over a period of time, things change. I think we need to give more importance to human resource development for health and their capacity building, which again needs to be need related and important for various issues that we have identified. On topic of financial management and health economics, I think your point about 3 countries within each country is very important. And I personally feel, it's my personal thing, we should not give free healthcare for all. There are 3 sectors of population. It should be free for those who are really poor, who can't afford. So they should not be devoid of what primary, even secondary and tertiary level of care. But those who can afford need to pay at least the cost of the services, and those who can pay higher, get funds from them and cross-subsidize for the poor.
And this model has been, I mean, you may be knowing, some of you, Arvind Eye Care System. That's one of the best economic models that has been appreciated world over, which depends on this. And their quality of service is same operation theater, same lens, but gives free services to the poor and charge to the rich. I think we should think about cross subsidy and government's policy of giving everything free. I think in long run we'll run short, particularly when you are spending only 1% of GDP. Lastly, I would just like to say that there are the three important A's for healthcare service delivery, but there are three different A's for service providers. One is availability. When you go to a clinic or a health center and you find doctor is not there or service provider is not there, what happens to the beneficiaries? The second is ability to provide services which based on your knowledge and skills. And the third one, which is the missing factor, is the affability, affectionate nature, doctor-patient relationship. We are just forgetting that particular art of healthcare. I think a human touch needs to be brought back to the healthcare system if we really mean business. Thank you very much, all the panelists and the audience, for a very interactive session. Thank you.
Well, it was truly a wonderful and enlightening session. Please give a huge round of applause to the chairperson and the speakers. Now I would like to request Dr. Piyush Kant Pandey to felicitate Dr. Damodar Bachani. Please give a huge round of applause. Thank you. Now I would like to request Dr. Damodar Bachani to felicitate Dr. Devendra Khadnaik. Okay. Mr. Rajesh Ranjan. Excuse me. Okay, ठीक. Dr. Richa Sen Gupta. I'm sorry, Dr. Richa Singh Dev Gupta. Professor Olga Plaza. बुलाना पंकज Now I would like to request you all, please be seated. Next session will going to be start. Thank you very much.
Just There is no tea break, please. Don't go.
Dr. Harsha Vardhan, Dr. Pankaj Gupta, Dr. P.R. Sodani, Dr. Piyush Kant Pandey, Dr. Gautam Sadhu, and Dr. Ruchi Garg to kindly take their seats on the dais. क्या बोला था मैंने?
Please. Dr. Devendra, please. Dr. Piyush, Dr. Sodani, Dr. Pankaj. पहले उनको स्पेशल गेस्ट को स्पीच के लिए बुलाया। पहले देवेंद्र, हाँ पहले देवेंद्र और फिर वो लेके
Nothing great can be achieved without greatness, and men are only great if they are determined to do so. Ladies and gentlemen, we are happy to have with us Dr. Devendra Khandet, Deputy Director and Country Lead, State Health Systems, India Office, Bill and Melinda Gates Foundation. Welcome, sir. We also have with us Dr. Harshvardhan, Founder and Group MD, Med Achievers and Genome Analyst. Dr. Harshvardhan is having more than a decade of multifaceted entrepreneurial experience. He is a mentor, orator, leader, investor, transformer, and game changer with immense capability of strategy and market establishment in healthcare. We welcome you to this session. Now, I would like to request Dr. Devendra Khandet to kindly encourage the students through your influential words. Sir.
Okay, so I was not knowing I am supposed to speak at this moment, but I just wanted to say how much I am happy to be here. Whenever I interact, and this I have already mentioned in my earlier comments, whenever I am interacting with the students of IIHMR in the field, in the diverse fields, I get inspired with their freshness of the thoughts. And so long as your new thoughts are coming, so long as you are challenging their conventional wisdom, I think we are alive, right? So please continue your flame of freshness, the new thoughts, the way you challenge your existing conventional wisdom. I'm so happy and thankful to the IIHMR team for inviting me for this important event, and I'm happy to be here. Thank you so much.
Thank you, sir. I would now like to request Dr. Harshvardhan to kindly inspire the students with your words of wisdom.
First of all, thank you so much for inviting me second time at IIHMR. I was here last year as well. I'm 100% sure post-lunch before awards, if somebody speaks, the back sitting students, they feel like if one murder is permissible, he should be the man today. But believe me, there is going to be a beautiful journey between you and me. In next 3 minutes, probably you are going to have your 30 years journey that you will have in your life. I heard yesterday, half of the day, because my flight landed at 1 in the afternoon. Today, I tried to be as patient, and I was in the room and heard beautiful discussions. Could see you guys were forced to sit inside for the room. Entire day you were inside. Some of you tried to take the last seat. There was no seat beyond the wall, so you started from there. So first time I saw, the room starts from behind, and it keeps, going thin on the front seat. I can see the front row is almost vacant. Then it goes thicker, and the full house is there on the back side. So everybody has a smartphone today? Take your smartphone out. Just take it out. Switch on the flashlight. You have a flashlight? Switch it on. Everyone, for IIHMR, put the light in this room. We need more light. These lights are not enough. No, everyone. We can see a stars in the room, so I'll have a selfie with the stars first. Let me have a selfie with our stars, who are the students. Now, you know what? That becomes our stage. We are the listener. That becomes our stage. We are the listener. You know why? We speak, we tell you a lot of things about our journey. We sometimes think it can be useful. Sometimes we think it should be useful. We actually don't want to read your mind because we don't have time for you. And like a shameless character, we come stand on the stage, tell you some gyan that we acquired thinking that is epitome of knowledge. I have realized that is not epitome of knowledge. What I have realized is every student is special. Because when I was a student, I was special. Really, I was special because I never wanted to listen to any of the things that said no. I wanted to, meet Amitabh Bachchan. People said it's impossible. I wanted to avoid Mr. Amitabh Bachchan. People said now he is completely mad. Let's not talk to him. When you do that, people say the madness works, right? So the story in your mind that forces you to sit in the back should drive you next time to sit in the front, because when I say how many of you want to be entrepreneur, you say everyone. Entrepreneurs steal opportunity. They are never given opportunity, right? And how many times we can talk about entrepreneurship? Do you know, in India we have 3% success rate, not 5 or 10% in entrepreneurship. But we have 100% success rate in intrapreneurship. So you should be an entrepreneur in your heart first. Everybody works for somebody else. If you think so, you won't work. Think every chair that you own is your chair. Every chair in any company is your chair. And then you become entrepreneur within that organization as well. So before I actually bore you further, I created 6 slides in my hotel room about one small journey that will correlate each one of you. In next 60 seconds, I would be sitting there and you can have your beautiful moments again. Can I have the slides, please? Oh, I need to do this as well? No, it's all good. So if you see, I'm saying it's a small interactive journey. Interactive, you know why? Because you will have to ask me questions. If not, I'll ask you a question because that is my stage. I am the audience. I would not be offending our senior people by saying they are audience. So I'm the only audience with some of the dignitaries on the dais and a lot of speakers in front of me. Are you ready to be a speaker today? Oh, no. If you don't say yes, you won't get any award. Believe me, I'll take all the trophies back Delhi. Believe me, I have got a big suitcase today parked outside. Are you ready to be the speaker? Very good. Can we just go to the first slide? See, it's a freshly baked slide. I have not prepared anything. I just was in my room. I was forced to prepare this. You can see a room full of people. Isko thoda chota karo yaar. Beautiful. You can see a lot of people in stress. You see a lot of people in stress? That is Indian Medical Association headquarters. 2014, I'm sitting on that chair with Chief of Armed Force Medical Services, NABL, NABH. भारत बदल रहे थे हम लोग उस दिन वहाँ बैठ करके. So, can you see it? What are we doing? My question is very simple. Why do we ideate? I need one answer. Who is the first person to answer this? Why do we ideate? You know ideation? Why do we ideate? Mike, DJ. Can we have a microphone there, please? What? No. I would say there is no need of change. We need to create first. We ideate to create. Because when you think so many intelligent people in one room, they give you all the reasons of being unsuccessful. They'll let you know all the challenges and make sure that you give up. They'll make sure that you give up. And so you will do it. You know what we were discussing? Can we have a platform where industry can speak to intelligent people? That means industry is not intelligent? No. We are talking about academia. Academia is think tank. Industry utilizes your intelligence. Can we have academia industry together? That was the discussion we were having that day in 2014. Believe me, today we are working with 29 universities and we have 432 industries working together. Can you believe it? In 4 years, we achieved that. Today in 5th year, we have direct presence in most of the leading universities of the world, and we have our incubation and ideation center inside the university now, as we think we'll have with IIHMR very soon. What I mean to tell here is, ideate to create, not change. Can I have the second slide, please? This is my journey, so would be very authentic. This is the output of your ideation. You get Amitabh Bachchan as award. So be crazy to an extent that people start believing you. For that matter, you have to believe yourself. Stop asking questions. Start committing mistakes. Commit mistakes as much as you can. Believe me, how many times one person can commit mistake? Either he will stop working or he will stop committing mistakes, right? So it's a good habit to commit mistakes. So I kept committing mistakes. I wanted to get declared craziest, worst, mad, but finally I wanted to achieve what I wanted to achieve. Still I have not achieved, so is the reason I'm standing here. Else I would be in Miami. Because then you have achieved. You don't need to go and talk to people. So still I feel we have done 0.1% of what we could have done. But this was the first success in 2014 itself. That you wanted to have a platform where you can have Amitabh Bachchan talking healthcare. Because you could talk polio do boon zindagi ki. Why can't he come and talk to people, share his journey and become healthcare entrepreneur? So I converted an actor into a healthcare entrepreneur that day. And that is first example of being crazy is not bad. Ideate and create. Can we have the next slide, please? This is an important question, and I would like at least including the leaders to ponder and answer. I'm saying merge problems. Generally, people say merge solutions, right? I'm saying merge problems. Do you agree with me? There is a boardroom you can see right from the chief of All India Institute of Medical Sciences to Swinburne University to CEOs of international houses sitting in a boardroom set up with me. And we are merging problems there. Believe me, we were merging problems that day. Why I say merge problems? Why not solution? Anyone, I mean, it's not limited to the students. Microphone, please.
Sir, it might be because some problems might have common solutions. So maybe if you merge problems, you might find a solution faster than looking at the problems individually.
Partially correct answer. I would say yes. When we merge problems, we can have a common solution. Can I have a microphone there, please? On the last row.
Good afternoon, everybody. We can merge problems so that we can find solutions together.
Yeah, it's the same answer. Something is missing here. Yeah, can we have the microphone there, please?
We merge problems so that we know of problems that we haven't even thought of.
Yeah, so I understand. This is very good. From our eminent faculty desk, can I ask the same question if I'm not offending you? I'm sure next time they're not inviting me.
Yeah. I do have a different point of view than merging problem. I rather believe in the diversification of the problems. I will encourage the people to ask more and more challenging situation, more and more problem. It is for the people to solve it in a cohesive way. So once you put the onus on people to ask unified problems, my worry is that you may be losing the diversification part of the problem. And that's why I'm not sure whether I'm agreed to that proposition itself.
Actually, the question is entirely different. I'll come back to you on that. But again, I would not dilute your thought with my thought here.
My take will be that sometimes the very thought of a problem is a problem. Sometimes the problem you need to ask that is it really a problem or is it an opportunity? So the very thought of a problem is a problem. That is number one. Second thing is, when you look and analyze many problems, then also you see a trend. Maybe sometime you are reacting in a certain manner, that is why you are inviting problems. So again, it will go back to my thing, self-reflection, so that you will know what it is and what it is not. And with a restless mind, you will never solve a problem. So you need to have a restful mind to solve any problem. Okay?
Yeah, so so I would answer it now. I would agree to him as well. So we merge problems because I have in my 14 years of career, we have done 42 ventures and 42 investments. Most of the innovative ones where you put more than $100 million, right? We got solutions in the problems. So we merge problems. When you merge multiple problems, you get the solution. One example, and I would be very clear. Yeah. Yeah, please.
Merging a problem, I do teach in the demography classes. If the students remember, when we ask to report an age, so we call it age misreporting. Particularly, it happened in early ages and in some advanced ages or in reproductive ages. Because even if you ask a very sensitive question, what is the age of the woman, even though her age is 19, she like to report 15, or even her age is 24, she like to report 20, that sort of things. So what happened in demography, what we do, so these are the error, these are the problems, so we club into a group. So instead of studying in 1, 2, 3, 4, we make it a group, 0 to 5, 5 to 9, so merging a problem. Meaning, if you put a problem together and for a short while you get an answer. So some of the problems get resolved automatically. So I just try to say that what is the scientific way in numerically also it is solved. So it is not. So if we study in a manner, even if you report 15, if you report 12, 11, I'm considering only the age group on 14, that way.
Yeah, so I'll give you one solution with this merge problems question, and probably you will understand what my perspective was. My perspective was to give you a practical answer. that would be summary of the 2 days conclave. See, we say we are a startup, we want to do a product, and we want to sell the product. So naturally, my whole problem is to have a product that can be a solution for others, right? For others, they are looking for a solution that can solve their problem at that point in time. So we were doing a smart ICU solution that can help our rural population to actually get critical care. And we had hundreds of startups, they applied with IoT devices, and they said, no, there is no taker of those IoT devices in healthcare. While I was reading both the decks, one was a problem deck, one was a solution deck, I merged the two, and the solution was with us in half an hour. And believe us, we didn't even spend 10 rupees extra. We merged the problems, and the solution was that the rollout has happened at Paras Healthcare Gurgaon now. And we are aiming to be in AIMS next week. In 32 to 33 hours, the entire modification happened. Because that device was completely ready. It was not for healthcare, by the way, but had all the features required for smart ICU. So sometimes you have to look at the problem in a different fashion. Look at a problem, try to ideate in a closed room, and make sure that the problem is not hitting you wrong. It's going to give you a lot of positivity. That one problem for one person, that is my product, and other person's requirement of the same product, if you have got a sane mind, if you got a nice setup and good team, can club the two and bring solutions to you. Can we go up, please? Let's have some more positive energy in the room. And so you go to create, industrial interactions. So when you do industrial interaction after having that merging problems and you have a solution with a smiling face, do you think you create opportunity or discover them? Do we create opportunities or we discover them? Exactly. We do both. Many a times we create opportunities, but most of the time we discover them. Like I'm discovering an opportunity that if I can sit with you guys there, I can talk to you more because you want to talk among yourself more than people sitting here. So my intention now is to go and sit with you there. But the opportunity given to me is to sit here. So naturally, I have to create an opportunity next time by requesting your Honorable President to be inside your campus and to sit with you guys and then see how many of you are really excited about entrepreneurship, job, or entrepreneurship, right? We'll go up. This is the important slide. You know why? Not because it has Michael Clark. All because we are creating celebrityship in healthcare. We are saying healthcare is not a boring sector. Healthcare is lifeline of everybody. A celebrity like Amitabh Bachchan, when he gets hit, he goes to a hospital. Our sportsman would need a sports doctor. Everybody needs healthcare. Everybody needs healthcare professionals. So can we have a synergy as a management professional today that we become part of their lives? We become part of the industries that drives them crazy, that drives them and their life. Do you think you can be part of their life or you can be a celebrity yourself? What do you think? You can be part of celebrity's life or you can be a celebrity? I mean, they should louder that yes, you want to be a celebrity. Who would not like to get a picture clicked outside? When you walk, people should recognize you for all good reasons. No one. Okay, raise your hands who would not like to be a celebrity. Who would not? Very good. That means rest of you want to be a celebrity. But you're not, do you need tea? Do you need some sort of energy drink here in the room to say yes? They need
But
tea.
Harsh, let me tell you, it also means that they are already a celebrity.
I would agree to Dr. Pankaj beyond 100%. I agree that you guys are already a celebrity. Believe in yourself and believe, on your work. These are the only ways, I don't know whether you are clapping to get rid of me or whether you're clapping because you're happy. But whatever is the situation, I'm loving it. Because I want to see that energy flowing in that room. I was very scared when they say you are going to speak at 4 o'clock before awards. I said, these guys don't like me somehow. Because afternoon, and then they said no tea for you guys. I was crying. I said, look, these guys are going to hit us very hard when I go from here and between the airport. But to be honest, I am very happy that I came here. I see you guys as future leaders in any of the leading organization or running your own organizations, depending on your aptitude. I would not force you to be an entrepreneur, or I would not force you to be employee or an entrepreneur. I would say during this course of 2 years or 3 years, whatever duration you are here, try and evaluate yourself. Your president was telling a very beautiful thing yesterday, that you should look at yourself first. And you should know who you are, right? And this has nothing to do with Adhyatma. This is all true. When I go home, when I look at myself, I don't judge my capability based on what others are saying or what others say I could have done. I do it because I love it. It has happened. Today we have 6 companies and 450 employees. When I started, I was alone. And it was a moment when you had a business card, you have your own identity, and you are the company yourself. From there to this place where you are standing in front of such a beautiful audience, beautiful, future leaders, and talking sharing dias with such knowledgeable people, I feel so happy that believing in yourself can drive you to a good place. You can do whatever you want to do. It's nothing to just promote energy in you. It is all about what I did in my life. I just wanted to give you a 6-slide journey. We are all ordinary people, It has happened by sheer conviction that if you can think, you can do it. If you can imagine, you can do it. With that, I would thank you all for keeping this patience hearing, not throwing any water bottles on me, and clapping all the time. Thank you so much.
Thank you, sir, for your enlightening words. Moving forward, I would like to request Dr. Ruchi Sogarwal, the Organizing Secretary Pradanya 2019, to summarize the conference.
Thank you. So I'll be very brief in my summary. I'm really fortunate to have our guest speakers and eminent speakers here in this 3-day deliberation. So I'm glad to share that we had 50 eminent speakers from industry, academia, and government. Are you excited about that? How many are excited about having industry speakers? Wow. And how many were very happy and delighted to interact with Shri Yaduvendra ji? Wow. And Sujata ma'am? Great. So, and really I'm excited to share that on both days, 24 and 25th, we have more about 90% of attendance. That's again a big round of applause in all the sessions. So if I combined our pre-conference and main conference, we total had 11 technical sessions. 11. My God. Our pre-conference session mainly focused on 5 thematic areas, One is private equity and growth drivers in health hospital sector. Second was on enabling public health workforce. Third was on medical device, self-management and personalized care. Fourth was on patient portal, and last one was health informatics. That means the pre-conference was heavily on technology and personalized care. So, did you learn something new there? What was new there? Anyone can just share? One? Only one. One thing which you learned new. No one? Anyone? Come on. My God, there is no one. Okay, I think they need team. You are right, Harshvardhan. Okay, last, we also had student competition. Yeah.
I'd like to just say one thing. I hope we had announced them that there is going to be a quiz on Pradanya.
Yes.
Where the first prize is 10,000 and there are prizes of 5,000 and 3,000. Are you aware about that, right? और तब भी आप learning नहीं बता रहे हैं.
So probably they want to keep their answers secret. That's why they don't want to share anything. So probably we'll see in the quiz, right? I think we had a poster and paper presentation, and we selected about 30 posters and 20 papers in this competition. And I think we'll be soon announcing who are the winners for that. I think you guys are excited about that. Are you? थोड़ा जोर से बोलो यार. Good. So now for the main session, the 6th main session which we had, first one was on befriending technology and healthcare efficiency. And I think Pankaj Gupta from Access Health International, he chaired that session, and very good conclusion which he has given is that though there is an ecosystem for artificial intelligence, big data, blockchain technology, etc., but there is a core concept of privacy, protection of data, which we need to take care of. So that is the summary of that session which Dr. Pankaj Gupta, Access Health, has given to us. Now, second session was heavily on industry and the government and the insurance combination experts who were there, who talked about value-based healthcare. And I think the basic fundamental thing which emerged from this concept is in this session is that payers, providers, and patient, they all have their own definition about value, price, and transparency. And the good thing which they highlighted is that we in this session talked about how to tackle this. That was the tackling part was very much appreciated by experts. Sudarshan Jain, who was the chair of the session, he highlighted that biggest challenge, whatever you do, whether it's a volume-based care or the value-based care, the biggest challenge which people or which the stakeholders face is creating trust among patients. That is the biggest challenge which exists. We need to figure out how we can address that. The third session was on health and well-being, new directions in preventive healthcare. And I think this session has highlighted very clear 7 new directions for us, which was chaired by Sujata ma'am. And those 7 directions were genetic testing, predictive analytics, standard EHR, AI, mobile and wearable devices, and encouraging innovation. So these are the directions for future of healthcare as far as the preventive healthcare is concerned. Next session was startup and health impact. So we talked about purpose-driven startup and health impact. And it was a great discussion which happened, again chaired by Sujata ma'am and Naveen Jain. So what the summary which Sujata ma'am concluded, given is that though government has given a lot of funding, mentoring, and other sort of support for fostering our startups and innovators in India, however, continuous dialogue, mindset change is required, not only focusing on product development, but also service delivery solution addressing the whole ecosystem. Next session was on invigorating rural India strategies for effective implementation of SDGs. And the key point which came up was that the livelihoods and achievement of SDG Goal 1 and 2 is primordial to achievement of health and well-being of all, which is SDG 3. SDG 6, which is about WASH, is also very important. So it's a time that the poor get ownership of their health. The last session was about 3 A's of human well-being, and this was chaired by Dr. Bachani, and other eminent speakers were panelists of this. And I think the key point which emerged was that there is the biggest roadblock of accessibility, which I think Devendra has highlighted, is the own mind, which is very interesting to hear. And we are, focus of the whole theme was on you. If you see our title of the conference, which is about the you is in the center part of it, and you means the mindset also. Then there was various models which Rajesh from Wish Foundation has shared to address all 3 A's. But the interesting part which was highlighted by Dr. Bachani in the concluding remark was the other 3 A's, which are ability, availability, and affordability. I think this is something which I'm very excited to hear about, the affordability of the care. So with this all, I want to end my summary with the, as in my welcome address, I said something, a shairi again, the shairi. I'm learning shairi from one of my colleagues, so now I'm just thought like, let me end with that. एक पल के लिए मान लेते हैं कि किस्मत में लिखे फैसले बदला नहीं करते। एक पल के लिए मान लेते हैं कि किस्मत में लिखे फैसले बदला नहीं करते, लेकिन आप फैसले तो लीजिए, पता नहीं किस्मत ही बदल जाए। So, I know a lot of our students are worried about their placement, a lot of students are worried about their future. So this is the, these are the words which I wanted to tell them, wanted to convey them. Don't worry about anything. You are there to rock the world. So with these words, I request Dr. Gautam to please.
So in each, the poster as well as the oral presentation. And let me tell you, besides the students of IIHMR, the students from Delhi, students from Baroda, students from Kolkata, and students from other colleges also participated in this Pradanya 24. So good clap for all of you. And many of them also participated in the poster as well as the oral presentation. So, shall I announce it? Okay, so first the poster presentation. And third prize, that is the bronze medal, goes to outside IIHMR University, that is Maulana Azad Institute of Dental College, Delhi. And the candidates are Dr. Choiti Sarkar and Vikrant Mohanty. Welcome. Yes. President sir and the guests are requested to honor them with the bronze medal and the letter of appreciation. And the silver medal for the posters presentation. Any guess? Amitosh Kaur and Bidusi Bharadwaj. Amitosh Kaur and Bidusi Bharadwaj. Health Management first year. Please come. Be fast. Congratulations to both of you. Come. Go there, better. Okay, now let's hold the announcement for the gold medalist. Let's come to the oral presentation. The bronze medal for the paper presentation or the oral presentation goes to Minal Chawla and Bhavin from SBDU Barodara. Please come in. They are the MBA Health Management second year, final year student of SBDO Barodara. And the silver medal for the oral presentation, any guess? Atharva and Dr. Vinny Dureja. Atharva and Vinny Dureja. And both are the first year students. So, okay, so now it's the time to announce the gold medalist. For the poster presentation, any guess? Say it again. Yes, it is Himadri Verma and Amritesh Misra. Himadri Verma and Amritesh Misra. Where is Himadri? Okay. Okay, fine. उसी को दे दो, उसी को दे दो. Okay, and for the oral presentation, the gold medalists are, two names are there. Of course, their author and the co-author. Any guess? Mayank Chhabra and Vineet Yadav. Mayank Chhabra and Vineet Yadav. Good clap for them, please. So congratulations to all the winners as well as all the participants who has participated, and all the presentation was really good, really good. Thank you to all of you.
Thank you, dignitaries, and congratulations to all the winners. Now, I would like to request Dr. Devendra and Dr. Harshavardhan to honor the organizing committee members. Dr. Akshata, Brijesh, Diksha Kumari, Jogender, Lalita, Purnendu, Sunita, Urvashi, Vicky, Celestine, Hamza, Mrunal, Meghna, Netra, Silva, Surender and Utkarsh.
Finally, बोर्ड ऑन द रायस सर्टिफिकेट भी नाम वाइज मिल रहा है, कोई दिक्कत नहीं, आ जाओ पीछे चढ़ने का मौका मिला मुझे। सही है, उनको काम आ गया। फोटो आ रहा है कि
I would now like to request Dr. Pankaj Gupta to kindly felicitate Dr. Dhirendra Khandet. I would request Dr. P.R. Sodani to kindly felicitate Dr. Harshvardhan.
So now I just want to invite Mr. Ramesh Gandhi. Ramesh Gandhi? Ramesh Gandhi? Anil Kumar, Sanjeev, Himanshi, Harish, Jitendra, Sanovar, Arpita, Yogesh, Swati, Atul, Akansha. Please come on the dais, please. Ashreya, Yash, Shruti, Chidambra, Savan, Aditya, Yukta, Anupriya, Krishna, Sindhu, Ruchika, Neha, Manohar, Shivani, Bharti, Bhavna, and Himani. All the content team, MRC team, editing team, marketing team, and concept visualization and mentoring by Ramesh. So this is the tabloid Pradanya. We want to release it. So we want to release tabloid Pradanya. And I think let's congratulate them. A big round of applause. Within 10 hours they done this. A big round of applause.
Some copies of the tabloid, please stand on the stage, please. I think the media has its own impact. The maximum number of people on the stage have come during this session. And I must compliment the efforts of every person who has contributed to making of this very small thing. And as we were discussing with Dr. Pankaj Gupta, the speed is a basic element of media. And you see, you get newspaper every day in the morning at your house, but huge network and manpower of editorial, photographers, printers, they are working in media house to bring that newspaper to your home. But this small effort was done by IIHMR students, faculty members, and marketing department, PR and branding department. Within 10 hours of conclusion of yesterday's session at 6 p.m., the team was able to bring out this session, this tabloid, at 8 o'clock in the morning. And we launched this thing officially in morning after the first session, in the beginning of the second session. And the beauty of this is that the content were developed by people, students from different streams, and I do not know the faces. The technology has helped. And photographs were being sourced from 7 different photographers. Marketing team, they were coordinating all in technology, and I was sitting at a very secluded place, and our team was working till 4 a.m. in the morning. And finally, when I informed Dr. Pankaj Gupta in the morning that a bulletin is ready, he said that's night, let's release it. So please give big round of applause to the entire team which they have contributed in words, photos. Big round of applause for them.
And my very, very special thanks to Gandhiji for making it happen. So again, very big round of applause for Gandhiji and the entire team. Thank you.
As we come to close our valedictory ceremony, I invite Dr. Piyush Kant Pandey to propose the vote of thanks.
I can see now, after such a grueling sessions of 3 days, you might not be having enough energy to clap, but this is the end, and end is the beginning. So, at this moment, when I'm standing here, because almost 2 days, 3 days ago, I started with a welcome note, welcome address. And today, when I'm standing to give the proposed vote of thanks, it's first of all, let me tell you,
You know, I just came in between. Before Pandeyji gives a very formal vote of thanks, let me share with you, as compared to the last Pradanya, this Pradanya has been really, truly exceptional and, you know, much beyond my expectation. Because I had certain apprehension, student will come, discipline, lot of things were there in mind. But because of all of you and the whole team, ably led by Ruchi ji, Piyush ji, and the whole team, I am very much touched by this whole endeavor, and a formal vote of thanks, which naturally Dr. Pandey will share. And I will just say one thing. In the last statement was from illness to wellness, and that was a journey from I to we. That is what we have to always keep in mind. Thank you.
in fact, that is the humbleness of our captain of our ship, Dr. Pankaj Gupta, because it was under his direction only, the entire arrangements, all students. In fact, I must tell you that, in fact, any words of formal thanking will not be able to cover all those people who have directly, indirectly, who have worked relentlessly, day and night also. In fact, this very room, on the first day, the people were working up to almost whole night to prepare it in the morning. So in fact, this all credit first of all goes to the captain of our team, Dr. Pankaj Gupta first of all. Second, I would like to formally propose a vote of thanks to our convener, Dr. Dhiren Kumar, then our co-convener, Dr. Gautam Sadhu, and also, some to me also, Dr. Piyush Kant Pandey, and Dr. Ruchi Sugarwal. You can see at every moment, she was there at every moment. She was in the forefront. She was the forward captain. So Dr. Ruchi Sugarwal, our joint organizing secretaries, Dr. Saurabh Kumar Banerjee, Dr. Piyusha Majumdar, then our faculty advisors, right now sitting on the dais also, Dr. P.R. Sudani, our pro-president, then our members, Dr. Sandesh, Dr. Alok Mathur, Dr. Sandeep Narula, then a special mention I must make of Dr. Sushmit Jain, and very special of Dr. Arpita Basak, who in fact made all the reporting possible for this particular tabloid also. So Dr. Arpita Basak, Dr. Ashok Pipliwal, Dr. Sajjad Parvez, Dr. Sujata Verma, Dr. Abhishek Dadhich, and Dr. Shweta Agrawal as the faculty advisors. Our marketing team, we have already congratulated them. So Dr. Ramesh Gandhi, Mr. Anil Kumar, Mr. Amit Gulati, Ms. Shivani Arora. Then our general administration team, in fact, all our administration activities over here, our nice food and lunching and all arrangements had been taken care by our general administration and finance team. So first of all, into this I must name Mr. Hem Kumar Bhargava. He was all along, every moment he was with us. Mr. Prasoon Jain as a finance person, Mr. Lakshman Sharoop, Mr. Achleshwar and Mr. Jitendra Kuldeep, who had spared no efforts in making this event a very great success. Then our student members of our team, Dr. Akshita Paropkari, Mr. Brijesh Kanjani, Ms. Diksha Kumari, Mr. Joginder Adhikari, Ms. Lalita Raja, Mr. Punendu Dubey, Ms. Silva Joshi, Dr. Utkarsh Saxena, Ms. Celestian P., Ms. Hamja Parvez, Ms. Mrunal Palsikar, Mr. Mrunal Palsikar, Ms. Meghna Raj, sometimes it happens. Then Netra Kadam, Dr. Netra Kadam, Dr. Sunita Kumari, Mr. Vicky Jain, and Dr. Urushi Jain. These are the members of the student members. And in fact, I must say the entire credit of behind the background working goes to this team, because they worked many days before, many weeks before of our today's function over here, as we are concluding over here. So special thanks goes to the student team for this efforts. Then finally, our faculty members, other faculty members also, who have directly, indirectly, and all the moment they have been encouraging, guiding, and providing the support to the student. That is the possible for making IIHMR as one of the best university. So credit goes to all the faculty, all the staff members, whose name I might not have taken. So credit goes to them. And a special mention I would like to mention now, our chairman, Dr. S.D. Gupta, and our trustee, Dr. Ashok Agrawalji, who had been a constant source of inspiration and guidance in our entire efforts. So that is saying thanks is a small word. And in fact, when Harshji was asking about the source of problem, I could only see and remember and think that we all are humans. We all share the same blood. We all share the similar DNAs. We all share the similar RNA. And therefore, similar problems we are facing, and the similar solutions also can come from this best enlightened crowd, best, I must say, the most disciplined and most inquisitive crowd over here. Credit goes to the IIHMR. Hip hip, hip hip, hip hip, hip hip. Thank you.
Thank you, sir. The end of a story is the new beginning for many others. On this note, let's conclude a remarkable, memorable, knowledgeable session. On behalf of the institution, we sincerely thank the dignitaries for being with us this evening and enlightening us with their enthusiastic remarks. I share my heartfelt gratitude to the professors, committee members, and every member of IIHMR family for their wholehearted support rendered in the success of this conference. Before we end the session, there will be a performance by Atharva and Utkarsha, and post that, all students are requested to wait for feedback session. Thank you very much. Have a wonderful and fun-filled evening.